All right, well, let's go ahead and get started. Welcome and good afternoon to Dementia Care Aware's fourth monthly webinar. Today's webinar will focus on aspects of the cognitive health assessment via video or phone. So hello, and welcome for joining us. My name is Josette Rivera. I am a geriatrician and professor of medicine at the University of California, San Francisco, as well as the education lead for Dementia Care Aware. I'll be moderating today's webinar, and I'm so pleased to be joined by Dr. Elena Tsoy, a clinical neuropsychologist and assistant professor here at UCSF. And welcome to Jennifer Schlesinger, Vice President of Healthcare Services and Professional Training out of Alzheimer's Los Angeles. So welcome, and thank you too for joining and presenting. I'm excited to learn from you. We have no financial relationships to disclose. And I want to start out by encouraging and reminding people that there is an online module that goes into depth on the cognitive health assessment. You can sign up for this training at this website and receive 1.5 credits of CME or CAMFT. So this is where to access the core training. And I encourage you, if you haven't already, to please go take it. But to help situate us for today's presentation, I'll briefly give an overview of the cognitive health assessment for those who are less familiar with it. It's 3 steps: taking a patient history, using tools to assess for cognitive and functional decline, and then establishing and documenting a patient support person and/or healthcare agent if they have one. The cognitive health assessment is designed specifically for busy primary care teams. And a couple of ways it does that is that it acknowledges and allows for different team members to administer parts of the assessment, which was the focus of last month's webinar. So if you haven't seen that, please check it out on our YouTube channel. And the cognitive health assessment can also be spread out over different days. So these are a couple of ways to address the shared challenge of time constraints. So I'll briefly go through each of the steps in turn. Taking the history, so taking a patient's history, the sources of information can come from a lot of different places in a lot of different ways. Patients themselves or their care partners might spontaneously report concerns about new cognitive symptoms. They might have a positive response on a self-administered annual screening survey, such as the Medi-Cal Staying Healthy Assessment for Seniors. There's a question on that about cognition. Anyone on your team might notice changes themselves, that someone is missing appointments or seeming more confused or noticing other signs or concerns that they might mention to the primary care provider. So the history can come from a number of different places. Step 2 is screening the patient for cognitive and functional decline. In the online module, we offer several options for doing this that have been validated in primary care settings. They include both cognitive and functional screening tools for the patient and for the informant if there is one and if necessary. And this is where we're going to focus today's webinar. We're going to hear tips and tricks for doing 2 example tools via phone or video. And then finally, establishing and documenting a patient's support, asking the patient if anyone is involved in their care, if they want anyone involved in their care, if they have a healthcare agent or someone who they have formally designated to make healthcare decisions for them, if they couldn't speak for themselves. So probing for these questions and documenting that person and their contact information, and then also equally documenting if they don't, and making a note to follow up on that at subsequent visits. So that's a very brief overview of the cognitive health assessment. And again, I encourage everyone, if you haven't already, please go to the online module and take the training in which each of those steps is gone through in much more depth. But again, I wanted to focus today on adapting pieces of the cognitive health assessment for telehealth, and I'll hand it over now to Dr. Tsoy.
Thank you so much, Gisette, for this introduction. I'm really excited to be here, and thank you for the invitation. It is very exciting to be talking about cognitive assessment via video, because this is a relatively new development. As you know, COVID has impacted healthcare in so many different ways. And I think this is just one of the kind of more novel modalities that we're exploring. So just to briefly introduce myself, my name is Elena Tsoy. I'm an assistant professor and clinical neuropsychologist. My primary appointment is in the Department of Neurology at the Memory and Aging Center. So again, because the topic is dementia, I'm very excited to be sharing some tips and tricks that we have learned in the course of sort of developing this new way of cognitive assessment using technology. Next slide, please. So the learning objectives for my portion of the talk today is to make sure that we all are able to describe logistical and practical considerations when conducting cognitive assessments using video technology such as Zoom or any other video modality, and also to apply learned skills and tips to conducting cognitive assessment using video technology within your own clinical settings. Next slide, please. Thank you. So I think I want to start off, as a neuropsychologist, I'm almost obliged to talk about the aspects of cognitive assessments that are incredibly important for the validity of the results. So cognitive assessment is incredibly standardized. The most important part about standardization is making sure that we are sort of controlling as much as we can of the patient's environment and also our own environment to ensure that whatever data we're collecting reflects the true cognitive ability of a person to the best possible degree. So the majority of standardized cognitive assessments or tools are typically developed and validated for in-person use, sort of face-to-face regular practice. However, as I mentioned, with the development of novel technologies, there is sort of this balance that we have to keep up in terms of trying to make sure that we are able to provide the services outside of face-to-face settings, but also making sure that we are maintaining the standardization as best as we can. So in the chart on the right of the screen, you can see that there are many different modalities for doing tele-NP, which stands for teleneuropsychology. Sort of, with increased validity, we are kind of reducing the safety. This was published in the context of COVID infection, of course. So there are modalities that allow you to do kind of home-based teleneuropsychology, where you're completely remote, you're connecting to the person via video. That has the most safe settings, but also has the most sort of threats to the validity. And then as we kind of move closer to actually in-person kind of regular settings, the validity is increasing. But of course, some of the reasons to not see patients in person could be many different reasons. Access is one of them, not just related to COVID, but also the fact that your patient might be residing very far away. Next slide, please. So in terms of existing evidence, as I mentioned, this is a relatively new field, both for research and for clinical practice. However, there are some studies showing that video administration, using technology and screen sharing, sort of like how we're doing it today, that several types of cognitive tools, particularly brief cognitive screeners, such as the mini-mental state examination, which is very widely used, or the Montreal Cognitive Assessment, another widely used tool, actually can be valid if you are following sort of the protocol, and also, again, making sure that you control the environment around the patient and yourself. Also, some literature shows that if there are certain cognitive tests that only use verbal information and do not involve the patient needing to draw anything or write anything, they generally tend to generate similar results if you compare the performance for in-person setting and then video administration. Next slide, please. Thank you. So I think I'm going to very briefly give you an overview of the cognitive assessment tools that are included in the CHA. Again, I believe you have access to them directly through the actual course. But just as a reminder, both the Mini-Cog and the GP-Cog, these two very brief screening tools, have been validated for use in primary care settings, and they both do not involve more than 5 minutes of actual testing time. If you look on the screen, you can see that the Mini-Cog involves 3 steps. It has the 3-word registration, sort of, this is where you read a list of 3 words to your patient and you ask them to recall it later. There's the clock drawing piece, and then there's the recall piece where you test the patient's memory for those 3 words. And then the GB-COG involves a little bit more steps, but sort of has a very similar paradigm where you're trying to test somebody's memory, including orientation, like what is the date today? You're trying to assess their executive functioning and visual spatial skills through clock drawing. Also, you're asking them about, again, memory-related recent information, if they can report anything to you about the news or an event that happened in their life. And then finally, recalling the information that you previously have taught them, the new information. In GB-COG's example, it's the address of a person. Next slide, please. Yeah, so I think I really wanted to focus on very practical considerations that we have learned through our practice doing sort of these telehealth video-based assessments with patients. And there are a few resources for you to check out if you're interested more. I'm happy to share them with you. But generally speaking, there are different types of characteristics you need to consider. Patient characteristics, your own characteristics where you are, and then the technological pieces that are involved. So we're going to start with patient characteristics. For patient characteristics, there are several things that you need to keep in mind before you attempt doing cognitive testing via video. The first one is the clinical and cognitive status. Can the patient effectively participate? One of the most commonly reported things is hearing issues. As you know, if you're talking to somebody via video, the sound is already distorted. So somebody with profound hearing problems who might not be wearing their hearing aids, or they may not have been adjusted yet, they might have a really hard time hearing you, which could potentially interfere with their ability to perform on some of those tasks. Like imagine reading a list of new words to someone who cannot really hear you. You won't really know if they cannot recall the words because they couldn't hear you or because they actually cannot remember. Does the patient have appropriate video technology? That's another important piece. We usually recommend to refrain from using something like a smartphone, because through a smartphone, you won't really be able to see the patient's environment as much. And you won't really be able to make sure that the patient has their hands free, that they're engaged in a testing and they're not sort of scrolling through or doing something else. Can the patient log in and effectively use the technology? Now, there is an asterisk for this one, because if you're seeing a patient who has a family member or a caretaker who is able to set up a session for you, and they're not really required to sort of, set up a Zoom link or anything else themselves, this can definitely happen, and this has worked very well. But if you're seeing a patient who does not have that level of support, you would want to make sure that they at least get some guidance from your office in terms of actually setting up and joining the secure session. And then, does the patient have physical space for a private and confidential session? That's going all the way back to this aspect of standardization. It is very important to ensure that the patient you're seeing for this very brief assessment is able to do this in a quiet and private and confidential space. There are many things that can interfere with somebody's ability to, recall certain things or how sharp they feel in the moment. And so the main reason for ensuring this privacy and confidentiality and quiet nature of the session is to kind of try and minimize all of those potential distractions. Next slide, please. So the next kind of aspect of doing video assessment we're going to talk about is technology. Technology is amazing, but it also can be challenging when we try to apply it to new domains. And so one of the things that actually American Psychological Association recommends is making sure that your technology platform is consistent with HIPAA compliant practices to ensure kind of confidentiality and protection of all the data that is being transmitted. You probably remember, or you have heard about the Zoom bombings that were definitely a thing in the middle of COVID, where basically people did not secure their sessions and a random person could have shown up in the middle of the class or evaluation and sort of disrupt the process. This has really brought up a lot of concerns because just like anything else you do in medical care, seeing a patient through video is a protected HIPAA compliant process. And so you would want to make sure that whatever technological platform you're using, they have the security checks in place in order to ensure that compliance. Do you and the patient have adequate internet connectivity for teleconferencing? That's another very common thing that shows up. Before you even set up a session, you would want to instruct your patient that they should have access to uninterrupted internet connectivity, whether it could be their home Wi-Fi or they're using a hotspot. You just want to make sure that both on your end and on the patient's end, the internet related disruptions are minimized. And kind of related to that point is also trying to ensure that the internet connection that both you and the patient are using are private and password protected Wi-Fis and not the public unsecure Wi-Fis. The reason why this is recommended is because, again, this is a secure, confidential medical appointment, and you would want to make sure that you have done everything on your part to protect the patient's confidentiality by ensuring robust technological background for your session. And the final point is very similar to the previous one, that the patient also has access to a secure connection. And then in terms of actual settings, settings usually refer to the sort of situation that you're in during testing and the patient is in. Getting back to the patient's location, again, we want to ensure that it's confidential and private, but also quiet. So a very frequent thing that shows up is I would be doing a testing with somebody, and then there's a dog barking, or and I'm in the middle of like reading a list of words to them that has to be very standardized. I cannot stop because I have to do it in a certain way. And so that significantly interrupts the actual flow of data collection and testing. So you would want to instruct your patient to be in the room by themselves without any significant distractions, ensuring that they're not sitting in front of a busy window, or ensuring that, their children or pets will not just run in, or that they won't have guests coming in to the room that they're in. All the things that are sort of very controlled in a medical setting, you would want to try and simulate it as much as you can in the patient's home environment. You would also want to ensure that you and the patient can see and hear each other well. When you're doing it on video, you would ask them to turn off their Zoom background so you can at least see that they're sort of in a well-lit, quiet room. Same thing with you. You would want to instruct both patient and also yourself to turn off any notifications or any apps on the device that they are using. For example, if you're using a laptop to connect with your patient, the first thing you would do is close all the browser windows, close Apex, close whatever it is that can be open for you, and make sure that you only have the window that you're talking to the patient through open, and you would instruct your patient to do the same thing. Again, this is all meant to ensure the best possible quality of connection and minimizing distractions. Phones are another common thing. You would want to ensure that your phone and the patient's phone are on do not disturb, at least for the duration of this evaluation that you'll be doing. And then finally, both for mini-cog and for GP-cog, you would ask a patient to have at least one blank piece of paper that is unlined and a pen before the evaluation. Most of the patients have them at home, so it's not a big deal, but it's sort of on you to try and remind them before you actually start. And okay, so kind of putting all of this together, you would want to do a quick pre-session checklist. You have a patient, you have scheduled an appointment, you have made sure that all of these previous aspects that we have discussed, technology, patient, setting, are all okay. And so you would want to do a pre-session checklist. First, you would want to sometimes verify the patient's identity if this is needed. If this is a patient you're seeing for the first time, you're not really sure what they look like. Obviously, if it's somebody you know very well, you won't need to do it. But depending on the setting and depending who's doing this appointment, this might be necessary. Again, this is all to ensure confidentiality and the validity of the process. You would want to discuss the backup plan in case of technical difficulties. I'll give you an example about the yelling distance. So I was seeing a patient who was had a lot of motor problems, and they couldn't really sort of move their limbs very well, and they had very poor fine motor control. And so something popped up on their computer that I am unable to see because I'm only seeing them through their webcam. And their caregiver went to walk a dog. And so we had to wait for their caregiver to come back so that we could get back to the session, so the caregiver could, click on the window to make it go away. So I think one thing that we recommend is that if there is a person who is helping your patient set up a session and connect with you, that they are not in the same room, but are within yelling distance, just in case any technical difficulties show up. You would also want to talk to the patient. For example, if your Zoom session just dies out and disconnects for reasons that you don't know, you would want to have their phone information and their caretaker's phone information on file, so you can call them and make sure that they are okay, just to make sure that they're safe and it wasn't related anyhow to their actual well-being. Which again relates to discussing the plan in case of a crisis situation. If your patient faints, for example, while you are doing this medical appointment with them, again, this is a medical appointment, even if you're doing it via video, you would want to make sure you have their contact information, the contact information of people who are taking care of them, or the contact information of the local emergency department in case you need to do a wellness check or make sure, to ensure your patient's safety in their remote location. You would want to review the importance of privacy at your and patient's locations, again, just to remind them that this is a private, confidential appointment and that they should treat it in the same way as they would when they come to your office. And then confirm that nobody records the session without permission. This is, again, one of those things where, all of the data that we're transmitting can potentially be hacked or logged. And so you would want to make sure that both the patient and you are not doing any recording unless absolutely necessary for clinical purposes. Next slide, please. All right, so going straight into the tips and tricks that we have learned while doing actual cognitive assessment. As you have probably noticed, there's a lot that you can do sort of before you jump into the actual testing process. And all the things that we have discussed actually make the practice of doing the assessment itself much smoother if you ensure that all of those things that we have discussed are in place. So in terms of practical considerations for doing both the GP-COG and the mini-COG, both of them include registration, or in other words, it's just, it's a fancy way of saying learning new information. On the mini-COG, it's a list of 3 words that they have not heard before, or they just don't know that you're going to have them learn. And on the GP-COG, it's the name and address of a person that, again, they haven't known before. So what you want to do during registration is, again, because you're in this remote setting, you would want to ensure that the patient is not writing down the words or the actual address you want them to learn. You want them to use their memory skills. And unfortunately, it's only natural, right, to want to just write down things that you need to remember later. But that is not the point of this assessment. So sometimes what I would have patients do is I would say, I'm going to read a list of words to you. I want you to listen carefully and try to tell these words back to me. And while you're doing it, I want you to show me your hands like this. So I just want to make sure that, again, on my side, I'm doing everything possible to ensure that what I'm doing is valid and accurately reflects patients' true cognitive abilities. For the clog drawing piece, again, it exists both in GP-COG and the mini-COG. It's a very interesting measure that tells us a little bit about patients' visuospatial functioning, a little bit about their planning, and a little bit about their executive functions. So you would want to ensure that there is no clock in front of the patient in the room. Because when you ask somebody to draw a clock, draw a contour, put all the numbers in, if they're just looking at a picture of a clock or looking at an actual clock in front of them, obviously this task is compromised. So you want to make sure they're not sitting in front of the face of a clock that they can look up to. And also when you're doing clock drawing, it might be difficult depending on how much experience you have doing these types of appointments. Once the patient has drawn a clock for you and you would ask them to show it to the camera so you can actually score it, you might want to take a screenshot of it in case you're not able to do it on the fly. because there are some subjective and sort of, more kind of precise measurement guidelines in terms of how to score the clock drawing. So you might want to take a screenshot and then, delete it later on your computer. And then finally, for orientation to date and recent events that is a part of GP-Cog, that is a very important and a very sensitive way to ask about somebody's memory. Unfortunately, given the nature of the computers, I can look up right now in the right top corner of my screen, and I could tell you what the date is because it's just on my computer screen. So what we usually do for these questions is we have patients close their eyes and tell us the date and the recent events with their eyes closed. This way, we're ensuring that the patient is kind of, doing this from their memory and not sort of looking up on different types of stimuli on their computer. Because again, the unfortunate reality is that we are unable to see their screen. And as much as you can do upfront to, make sure that you tell them and ask them not to have anything, I don't actually ever know what they're looking at on their screen. So just making sure that, again, you as the examiner provide as valid of an assessment as possible. And next slide, please. And there are also, as Josette kindly reminded us, there are parts of the assessment that involve the informant. Usually, the informant pieces come after you actually do this cognitive testing piece. And the informant interview questions are very standardized. They are published as a part of these tools that we have discussed. They can be completed by sharing your screen with the actual document. For example, the GP-Cog just has the informant part, which lists the questions. So once you're done with the patient and the patient is no longer looking at the screen and you now have this confidential one-to-one session with the informant, you can share the document and you can complete it together. And very similar to patient-facing evaluations, you want to ensure that the setting and the sort of the setting in which you're collecting this information from the informant is as private, as confidential as possible. Because in the home settings, the patient might want to be a part of this, of the informant interview data collection. And this is definitely up to you because the decision usually relies on the doctor in terms of whether you think that the informant would be able to report information openly and honestly if the patient is there. Is there any interference? Are there any family dynamics that might impact the results? So it's a case, you do it on case by case basis, but regardless of that, because it's a home environment, many patients and caregivers feel like it's very different from being at a doctor's office, but you just want to make sure that your behavior and the way that you're setting up the session simulates the actual medical setting as much as possible. Because again, I cannot stress enough how important it is to keep this as professional as possible and make sure that both the patient and the caregiver understand that this is a confidential medical appointment. And next slide, please. And yeah, those were all my slides. And I actually think this is a great segue to Jennifer's talk, who's going to be talking to us about doing cognitive symptom surveys via phone. And I think I gave a quick introduction, but I am delighted to hear from you, Jennifer.
Thank you so much. Appreciate the opportunity to speak to you all today about a validated cognitive screening tool that you can use telephonically. So I first became acquainted with the AD8 about 8 years ago when I was working on the Dementia CalMedi Connect project, which was a statewide program focusing on increasing dementia capabilities within the duals demonstration. This was the integration of care for people dually eligible for Medicare and Medicaid. And Alzheimer's Los Angeles convened a group of dementia experts to consult on a validated cognitive screening tool that would be most appropriate for care managers who were working telephonically with members. And they recommended the AD8, and I have been teaching this tool for about a decade now. So my hope today is to provide some tips for administering the AD8 via phone and highlight some ways that health plans can support the cognitive health assessment in clinic. There are some nice synergistic opportunities that I'm going to highlight, and I hope they will open some doors for more coordination of assessment and care. Next slide. So let me begin by sharing the AD8 dementia screening interview. This is a validated cognitive screening tool that can be used telephonically. It includes 8 items, and we're looking at whether there has been a change in the last several years caused by cognitive problems. So the items include problems with judgment, less interest in hobbies or activities, repetition of the same things over and over, trouble learning how to use a tool, appliance, or gadget, forgetting the correct month or year, trouble handling complicated financial affairs, trouble remembering appointments, and daily problems with thinking and/or memory. This tool is free to use. It's available in multiple languages, and it's best used with an informant, such as a caregiver, but it can also be used with the member or the patient. Next slide. So when administering the AD8 by phone, having some rapport with the informant or the member patient can be very helpful because this helps facilitate more of a natural conversation. We first introduced the screen, and a couple suggested introductory statements that hopefully are not threatening to families include, I'm going to ask you some questions to help better plan for your care, or if you're speaking to an informant, to help better plan for your relative's care, or something like, I'd like to do a quick screening with you about your memory. Then read each statement aloud to assess whether there has been a change or no change in the last several years. Because this is a validated tool, it's important to maintain fidelity to the language on the tool. However, there is some language on the AD8 that is outdated, such as a reference to a VCR, though I assume that some people may still have VCRs. It's probably pretty antiquated for most people in 2022. So given that we're using this tool to truly assess for cognitive issues, making slight adjustments to some of the language as necessary is okay. Next slide. The AD8 is scored by adding up the number of items marked yes, a change has occurred, and 0 to 1 indicates normal cognition, and 2 or more shows that cognitive impairment is likely present, meaning that additional assessment is needed. Next slide. So who has been using the AD8 in California? I'm going to take a step back and share some context about how this tool has been used in our state. And my hope is that this may help you understand how you can plug in to existing processes. In CalMedi Connect, as I mentioned, California's duals demonstration, care managers at health plans were trained to use the AD8. Some of these care managers went on to become dementia care specialists, and these were mostly nurses and social workers. The training of care managers and dementia care specialists on dementia best practices, including the use of a validated cognitive screening tool, has continued for almost a decade now and included 10 health plans that were part of CalMedi Connect, as well as provider and medical groups. And as CalMedi Connect is going away and we are moving into our state's program called CalAIM, California Advancing and Innovating Medi-Cal. This is our state's 5-year initiative that will change the way people who are dually eligible for Medicare and Medi-Cal, as well as older adults on Medi-Cal, receive health care in our state. And the folks that were in CalMedi Connect health plans who will be going into dual eligible special needs health plans, those care managers and dementia care specialists are the folks who have been trained in the AD8. So to date, we have trained over 890 care managers in California on how to use the AD8 and how to communicate the results of the AD8 to the primary care provider. Dementia Care Aware provides an opportunity to make sure that there is what I'll call connective tissue between health plan care managers and dementia care specialists and what is happening in primary care. Next slide. So we've learned a lot from the hundreds of care managers and dementia care specialists who have been using the AD8. And one of the things that's been shared is that they have found that having a tool that can be used with lower income and diverse communities and also an older patient population is really valuable. And having a telephonic tool specifically is both acceptable as well as accessible with lower income, diverse, and older communities. So at Alzheimer's Los Angeles, we have seen that web-based platforms can be very challenging for some communities, especially those that are non-English speaking. And we know that the digital divide is a real challenge and barrier at times. So a good old-fashioned telephone works well for many older, diverse, and lower income families. Our care managers and dementia care specialists have shared that the AD8, it's simple and it's quick. However, some of them have also shared that utilizing this tool can lead to more in-depth conversations, which can actually be very insightful and helpful when determining and creating care plans. With basic training, the AD8 is easy to administer as well as score. So the bottom line here is the telephone is not yet obsolete, and using a validated screening tool over the phone is simple as well as accessible. Next slide. So I want to encourage those on today's webinar to consider the synergistic opportunities between CalAIM and our DSNP plans, our dual eligible special needs plans. And the work that's being done in those health plans with their care managers and dementia care specialists, as well as the work that our primary care teams are doing in clinic. Health plans serving duals, or those who are dually eligible for Medicare and Medi-Cal, they have a health risk assessment trigger question focused on cognition. They're actually mandated to have this particular question around cognition in their health risk assessment. And the question asks, have you had any changes in thinking, remembering, or making decisions? From that trigger question, care managers at health plans, including dementia care specialists at health plans, have been trained to then use a validated cognitive screening tool. And in many cases, this is the AD8. After the cognitive screen is administered, the care managers and dementia care specialists provide the results to the primary care provider for further assessment. With Dementia Care Aware, this is the cognitive health assessment. So in other words, the cognitive health assessment process, in some cases, may have already begun with your health plan colleagues. And providers can leverage this because the AD8 is an approved screening tool for the Dementia Care Aware cognitive health assessment. Care managers and dementia care specialists at the health plans can also work with you to develop best practice care plans once a diagnostic workup has occurred. And by working collaboratively, the hope is that we can better coordinate care for lower income older adults throughout the state of California. So I will go ahead and stop there. This is my contact information, and I will hand it over to Gisette.
Thank you both for such wonderful practical presentations. We're now going to advance to the question and A part of the webinar. But before we do that, we have a quick poll question about how you heard about our webinar. So I will let my colleague post that poll. And hopefully you can see it, and just take a second. This helps us understand how we can better market this resource. Okay, so now we'll return to the Q&A, and I see 3 questions, and maybe what I'll do is read them aloud, and Elena or Jennifer answer as appropriate. So the first question is, I think, for Dr. Tsoy. When you set up the controlled environment as you describe, and then ask them to close their eyes or hold their hands up, are you not adding stressful factors that could negatively impact the results and the participant? While you are trying to keep them from using environmental cues so the results won't be skewed, the ability to do so indicates competence on the part of the individual. Ultimately, how does the participant benefit from being treated in this artificial manner?
Thank you. I think it's a great question. And I do appreciate the deep thought behind sort of caring for your participant or patient in this case. I think at least in our experience, the most artificial part of doing cognitive assessment via video is the video part, because typically when somebody comes into your medical office, you could argue that this is also a very stressful and artificial environment. It's not ecologically valid to how they're doing in their daily life. And so in a way, trying to ensure the standard collection of information, asking the patient to close their eyes, or, we're not asking them to sort of run a mile. But it is, remember how the chart that I showed you about balancing validity and safety? I think we're ultimately trying to enhance the validity as much as we can. Stress is a part of any type of cognitive assessment. Trust me, I'm a neuropsychologist. I have been doing this for 10 years, and every single time I ask patients to remember anything, they're very stressed because it is a very kind of anxiety-provoking type of assessment, particularly for older patients. So I think what I would encourage you to do is, again, just like with everything else, you would want to build rapport with your patient as much as you can when you're setting up that session. And you would want to ensure that the data that you're collecting are reflective of the questions on the instrument. As much as I appreciate your comment about if people are able to use environmental cues, or like they're able, for example, to open a news website and report recent news to you by reading what's been happening, you're not really testing their ability to read the news or to find the news. You're testing their memory, and you would want to make sure that the information that you're collecting is specific to the information that is listed on a standardized tool, just as you would as in-person settings. So I hope I answered that question, but please feel free to follow up or reach out to me via email.
Thanks, Dr. Tsoy. The next question is the 88 licensing available to all providers? It looks like the licensing is limited to certain settings. Maybe Jennifer, can you speak to that?
Yeah, I'm going to have to look into licensing. When we first started using the 88, we had permission to be using it with our health plan partners, and there wasn't anything, but all of these tools do change over time as far as licensing goes, as well as cost as well. My understanding is that the 88 requires a license, whether it's in the for-profit or nonprofit research or clinical use, and that's through Washington University School of Medicine in St. Louis.
Thank you, Jennifer. All right, moving on. Can family members do the assessments before seeing the primary care provider? And maybe I can speak a moment to that. I think the answer is yes, but it's highly dependent on how the workflow is implemented in your clinical setting. So some workflows might ask family members to fill out questionnaires before the visit, and some might as a consequence of the visit. So it just, I think, is highly dependent on your particular organization's workflow. I don't know, Jennifer or Elena, Dr. Tsoy, if you have anything to add to that.
I totally agree. I think just that being flexible about this and sort of making sure it works within your clinical setting and how you usually do these types of assessments with patients, I think is extremely important.
Thank you. Okay, moving on to the next question. I think it's a question comment. This is not exactly about telehealth cognitive assessments, but rather how to get the info more consistently that has been gathered by health plans. Jennifer's comment about collaborating with health plan care managers is a good idea, but are there ways to improve the communication with the healthcare plans? I get these HRAs from my older fragile patients, and they often have no memory of talking with the care manager, and it is difficult to weed through the many pages of the HRA to find the important elements related to memory.
That has been a challenge, the collaboration and the communication between the health plan and the clinical setting. And we know that, at least in CalMedi Connect, there are requirements for interdisciplinary care team meetings as well as care plans that are shared. But we know that those are not always attended by everyone, nor are the documents always thoroughly read. So there's some real opportunities here for us to improve how we're communicating across settings, because there certainly are challenges. But Dementia Care Aware kind of presents a new opportunity, because years ago when we started doing training at the health plan level of care managers and dementia care specialists, they would say, there's nothing we can really do after we do the cognitive screen. We share the results with the PCP, but there's very little we can do in this space. And now with Dementia Care Aware, we have our primary care providers and teams being trained on these various tools and how to continue that workflow process. So we are hopeful that with Dementia Care Aware, there are more opportunities to strengthen the communication at those various levels, but there are still some significant challenges.
Thank you, Jennifer. So appreciate your experience with that. Moving on to the next question. I think it might be appropriate for either one of you. Since the 88 is better completed with informants, have you tried to harmonize its scores with the tool completed with the patient? So you could use one or the other depending on who's available for the interview, but still have comparable longitudinal measures.
That's a wonderful question that I will not answer because I'm not a clinician.
I can take a stab at it. And I think, I know this is a very frustrating answer, but I think it really depends. So if, when you're thinking about longitudinal measures for clinical care, and let's say you're trying to use the 88 as a disease monitoring tool, right? Like how much function, how are they doing functionally, how fast are their cognitive symptoms progressing? I would say the most important thing is probably stability in those types of settings. If, for example, the caregiver is not available and you only have access to the patient, then, if you've done it with a patient, then I would probably suggest that you continue collecting information from the patient. However, I would say in our clinical settings, and obviously we are a specialty neurology setting, but we always want to ensure that we get information from somebody who doesn't have to be a family member. It can be somebody who knows them very well. It can be an old friend, it can be a neighbor, because oftentimes when we work with neurodegenerative disease, the unfortunate reality is that anosognosia, or inability to understand your own limitations, is a very common presentation. So oftentimes, if the patient is just self-reporting the symptoms and there is no corroborative information, it's very difficult for us to make conclusions about how functionally or cognitively impaired they are in daily life. So I would probably, for your clinical care, I would encourage you to try and work with a caregiver when you collect these data.
Thank you, Dr. Tsoy. Yeah, I think there's a practical nature. I can't cite research data that compares tools head to head, but I agree with the concept that whatever you do, that you repeat that and you're consistent across time with the same tool and the same person. Jennifer, were you going to say something? Okay. All right. Next question. How much are these assessments? Aside from licensing, they're all free to use, and that's why they were chosen. These tools that we cover in the more in-depth in the online module on the cognitive health assessment were all chosen because they've been validated in primary care settings. They're very quick to do and they're free. And most of them come in multiple languages, which is another question. But before I do that, there's a question. Are we getting the handouts of the presentation? And thank you for the shout out, Maria. Can someone answer that from the Dementia Care Aware team? I know that after this webinar, the recording is posted on our YouTube channel, but do we also post handouts? Rita, can you answer that?
Sure. We usually don't post handouts, but we can try sharing the slides.
Okay. Yeah. So maybe Maria, if you care to share your email address, we can create a slide handout for you if you want. Next question. Translation involves culture, familiarity of those words. Would you share with us some insights in working on translated versions such as Spanish and Chinese?
Is this involved? I'm wondering if this refers to ADA piece or
it doesn't specify the tool, but let's just say maybe a generic cognitive screening tools and how share some insights in using any cognitive screening tool in other languages.
Yeah, I think that's a great question. I really appreciate you asking that because I think when it comes to cognitive assessment, you're absolutely right. It's not just the words themselves, right? Even if we get like actual literal equivalents in another language, some of the questions might not apply, an address that is somewhere out of Ireland might not work for somebody who grew up in Africa. And so you would want to make sure that whatever tool you're using has been validated in the population you're serving. I do believe that Minicog and GPCog have shown quite high validity in terms of detecting cognitive impairment across different populations. There is a lot of information about it on, the research literature. And I think the primary purpose of doing an evaluation is making sure that you are using something that has been used in this population previously. So if you can find reliable information, whether it's research, whether it's the clinical practice, whether it's through a specialist who recommends it for you, I would say it works well for these types of assessments because they're very brief and they typically do not involve in-depth, kind of like a typical 4-hour neuropsychological assessment session. They don't involve this sort of detailed assessment. So they try to build, both Minicog and GPCog developers try to build the questions in a way that could be globally applicable. And that's why, for example, if you ask somebody about recent news, they all might report very different things to you. Somebody watches TV, somebody reads the paper, somebody just reports recent events in their own life, but they are very valid in terms of their actual experience. So I would say when it comes to cognitive assessments, there is literature about it, and you would just want to make sure on your part to learn as much as you can about your patient's background and choose the tool that works well for them based on previous findings. And I think I'll defer to Jennifer for the 88 piece because I know that it has been used in diverse populations, but I have not actually used it myself.
Yeah, I mean, there are versions of the 88 that have been validated in different languages. I know it's in Spanish and French and Portuguese, Chinese, Korean, Taiwanese, and I believe Arabic as well. When I did some initial research into the 88 in different languages, I believe like the 88 that was validated in Spanish was validated in Spain. And so clearly there can be some linguistic differences between Spanish in Spain versus Spanish in other countries. So there are limitations, with all of these tools and whether or not they're just translated, for a particular geographic area, and of course, culture plays into that as well.
Thank you both. Well, I am recognizing that we have 5 minutes left, so I will take the last question I see. What is the link for the assessments? So that's a two-part question. First of all, if you go to the website I showed you on the first slide and register and take the online training, they're embedded within the online training. All of the tools have links. And then secondly, we are working on providing those links, I believe, upfront on our website. So that's a work in progress, however, but if you would like access to them now, please register for the online training, take the training, it's free, and you can see our table with links to each of the tools that you can use for the cognitive health assessment. So I believe we've covered all the questions, which is almost perfectly on time. And the final thing I want to leave you with is how to claim continuing education credit. Hopefully you see the appropriate slide. Great. So Rita will also put instructions in the chat, but here is a two-step process for one, completing evaluation of the webinar, as well as how to claim credit. And I think and it's also here in the chat, and you can cut and paste that if you like, and put it wherever you need it. And then Danielle also posted a link to the online trading and the table with the links. I'm sorry, the table with the links. So thank you, Danielle. So with that, I will conclude this webinar by thanking Jennifer and Elena for their thoughtful presentations and for fielding questions, and especially say a thank you to you for joining us and providing feedback. And we hope to see you next month.
Thanks, everyone.
Thank you.